The left renal vein, as it lies between the aorta and the superior mesenteric artery, resembles a nut between the jaws of a nutcracker.
Okay, let's unpack this rather vivid image from 1937.
It really paints a picture, doesn't it?
It does. What
Yeah.
we're diving into today is a relatively rare and, it has to be said, somewhat controversial vascular condition.
Oh.
It's called Nutcracker syndrome, or NCS.
Uh-huh.
And as that quote so strikingly illustrates, the very name comes from this anatomical setup.
Mm.
So the big takeaway right off the bat, we're talking about a literal squeeze happening inside the body.
Exactly. The nutcracker in question is the compression of the left renal vein. That's the vessel draining blood from your left kidney.
Okay.
And it gets compressed as it passes between the aorta, the main artery from your heart, and the superior mesenteric artery, or SMA, which supplies blood to your intestines.
So the aorta and SMA are the jaws.
Precisely. They're the jaws of the nutcracker, and the left renal vein is the nut being squeezed.
Gotcha.
It's also important to mention this compression can occur in a retroaortic position too. Retroaortic, meaning behind the aorta.
Yes, where the left renal vein is squeezed between the aorta and the vertebral column of your spine. So like the nut being cracked from behind, if you will.
Okay, another variation.
And even rarer are atypical forms involving something called a left-sided inferior vena cava.
Wow, okay, so we have this anatomical crunch point. But it's interesting, isn't it, that doctors distinguish between the nutcracker phenomenon and the nutcracker syndrome.
That's right.
It's not just about having a squished vein, is it? It's about whether that squish is actually causing problems.
That's a crucial distinction, absolutely. Nutcracker phenomenon, or NCP, simply means that this compression of the left renal vein is present on imaging.
Just seeing it on the scan.
Exactly. Many people might have this to some degree and never experience any symptoms at all.
Right.
Nutcracker syndrome, or NCS, on the other hand, is when this compression leads to a whole range of symptoms. And this is really where the controversy comes in.
Ah, okay. Why the controversy?
Well, some argue whether NCS is a true, distinct clinical syndrome. They point out that, a certain level of LRV compression is often seen as normal. Plus, surgeons sometimes tie off the LRV during other operations without major issues. And like we just said, many individuals with a compressed LRV remain completely asymptomatic.
So the big takeaway here is just because a scan shows a squished vein doesn't automatically mean someone is sick.
Precisely. It's all about the symptoms. The mere presence of the nutcracker anatomy doesn't automatically equate to this syndrome.
Right. It's the so what factor that matters. Now, this isn't a brand new discovery, is it? This idea of a vascular nutcracker.
Not at all. As that opening quote shows, the analogy was made by anatomist J.C.B. Grant way back in 1937, just looking at anatomical specimens.
Wow, 1937.
But the first clinical reports actually describing patients with symptoms potentially linked to this came from Egyptian urologist El-Sad and Mina in 1950. Then, in 1971, Chait and colleagues really brought the anatomical picture to life, using venography, that's a type of X-ray where they inject dye into the veins.
Right, to see them better.
Exactly. And they were the first to actually use the term nutcracker to describe what they were seeing on those images.
And the full syndrome name came a little later, right?
That's right. In 1972, a Belgian radiologist, Dr. De Schepper, officially named the disorder Nutcracker syndrome.
Okay.
He was key in linking this LRV compression, not just to the anatomy, but also to things like pelvic and perineal varicoceles.
Those are like varicose veins, but deeper inside.
Kinda, yeah. Dilated, twisted veins. And he also linked it to a symptom we'll talk about a lot, a hematuria, which is blood in the urine.
Hematuria.
And just a couple of years after that, in 1974, Pastor Schenck proposed the first surgical effects, transposing or basically moving the left renal vein to relieve the pressure.
Moving the vein itself.
Yes. So it's been quite a journey, from just seeing it in cadavers to understanding it as a real clinical issue that might need treatment.
So from an anatomical observation to a described syndrome with proposed treatments, that's quite a journey indeed. And that brings us to why we're taking this deep dive today.
Well, our mission here is to really explore the ins and outs of NCS.
Yeah.
The background, how it's diagnosed, and the different ways it's managed.
And it sounds like there's still some debate.
Oh, definitely. It's important to acknowledge right off the bat that because it's relatively rare and can present so differently from person to person, there isn't really a clear consensus on the best ways to approach it. You often have multiple specialists involved in a patient's care: urologists, vascular surgeons, nephrologists, which kind of highlights its complexity.
So for you, the listener, think of this as your shortcut to getting a good grasp on the essentials of this complex condition. We're aiming for those aha moments without hopefully overwhelming you with too much detail.
Mm-hmm.
Okay, so we know what the Nutcracker is and a bit about its history. Let's delve into the background. Who gets this and why?
Well, nailing down the exact prevalence of NCS is tricky. The main reason is, as we've touched on, the lack of universally agreed upon diagnostic criteria.
Makes sense if you can't agree on how to diagnose it.
Exactly. It's hard to count it. But looking at the data we do have, initial thinking suggested it might be more common in young women, maybe in their teens and 20s, with perhaps a second peak in middle age.
Okay.
However, more recent studies have actually indicated that it might be equally prevalent in men and women, and it can certainly occur in older patients, too.
So the thinking has shifted a bit.
It really has. It underscores how our understanding of who gets NCS is still developing, and we probably can't rely entirely on those older assumptions.
That's interesting, the shift in understanding the demographics. What about the phenomenon itself, NCP? Just the anatomical finding without symptoms, how common is that?
That's a good question. Interestingly, radiologic studies looking at abdominal CT scans done for completely unrelated reasons have found NCP, that is the LRV compression, without symptoms in around 10.4% of people.
Wow, over 10%.
Yeah, and in those cases, there was no significant gender difference.
Okay.
One factor that does seem to correlate, though, with developing the syndrome, NCS, is a lower body mass index, or BMI.
So being leaner.
Essentially, yes.
Yeah.
Being leaner seems to be associated. And it's also been observed, anecdotally perhaps, that a significant portion of the published literature on NCS involves patients of Asian origin.
Interesting. Is that confirmed?
We need to be careful there. There haven't been large population-based studies to really confirm if there are any actual ethnic, racial, or geographic risk factors. It's more of an observation from the existing literature.
Got it. And genetics, does it run in families?
The evidence overwhelmingly points to no hereditary link. There's an exception, a single case report involving 2 siblings, but otherwise, it doesn't seem to be genetic.
Okay. So a few potential associations, like BMI, maybe geography, but nothing definitive in terms of who is more likely to develop the symptomatic syndrome. Let's go back to the anatomy. We've talked about the standard anterior compression.
Between the aorta and SMA, yes.
But there are other variations, right? You mentioned the posterior one.
Absolutely. The most common type is that anterior NCS.
Yeah.
But then there's posterior NCS, where the LRV is retroaortic, meaning it runs behind the aorta.
Okay.
And gets compressed between the aorta and the vertebral column, the spine.
Right.
And then you have the really rare atypical NCS. This happens in individuals who have a left-sided inferior vena cava. The IVC, the major vein returning blood from the lower body, is on the left instead of the right.
Which is unusual in itself.
Very. And in those cases, the LRV and the IVC can both be compressed between the aorta and the SMA. So even within this rare condition, there are rarer subtypes.
Left-sided IVC, that's quite an anatomical twist. Are there any other things that can act like a nutcracker, even if they're not the typical aorta-SMA duo?
Yes, there are a number of other anatomical variations and even certain medical conditions that could potentially lead to LRV compression. Though whether they truly cause NCS is often debated. Things like pancreatic tumors, enlarged lymph nodes around the aorta, other retroperitoneal tumors, those are tumors in the space behind your abdominal organs.
Okay.
Even an unusually positioned testicular artery or bands of fibrous tissue, fibrolymphatic tissue between the SMA and aorta. And notably, the compression of larger veins by a pregnant uterus has also been implicated.
So it's not always just the 2 big arteries pinching the vein.
Exactly. It's not always the classic picture.
Now, when we talk about the compression itself, are there typical measurements involved? Like, how narrow does it have to get to be considered a problem?
That's a good question. Normally, the distance between the SMA and the aorta at the level where the LRV crosses is on average around 4 to 5 millimeters.
Okay, pretty small space already.
It is. And in studies looking at cadavers, the left renal vein itself has an average diameter of about 1.1 to 1.2 centimeters. Ultrasound studies in living people without NCS tend to show slightly smaller LRV diameters, maybe in the 4 to 5 millimeter range.
So what happens when it gets compressed?
Well, in anterior NCS, this compression can lead to the gonadal vein, which drains from the testicles or ovaries, becoming dilated and engorged.
Like a backlog?
Exactly, like a hose with too much water backing up. You can also see a lot of pelvic lateral veins developing. These are like alternative routes, detours for blood to flow when the main path is squeezed.
And these pelvic collaterals can cause their own set of issues, right? We hear about pelvic congestion syndrome.
They absolutely can. That anterior NCS-related LRV hypertension, the high pressure, can indeed lead to gonadal vein reflux, meaning blood flows backwards down that vein.
Okay.
This contributes to pelvic venous disorders and potentially pelvic congestion syndrome, or PCS. The left renal vein is a really key part of the pelvic venous outflow system.
How so?
It's the most downstream point before blood reaches the main IVC, and it has important connections to the gonadal veins, which then link up with veins in the pelvis like the internal iliac and common femoral veins. There's a lot of cross-pelvic drainage happening naturally. So when you have LRV hypertension, that high pressure can cause blood to back up into the gonadal veins and then flow backwards down into the pelvic veins, causing them to become varicose and symptomatic.
So it's like a traffic jam on the main highway, backing up onto the local streets, causing gridlock there, too.
That's a great analogy, yes.
But it's interesting that just having dilated gonadal veins on a scan doesn't automatically mean there's reflux or PCS caused by the Nutcracker, does it?
That's a critical point.
Yeah.
A recent study actually showed that the diameter of the gonadal vein doesn't reliably predict whether there's actual gonadal venous reflux in patients with pelvic venous congestion syndrome that isn't related to renal vein compression.
Oh, interesting.
They found that many normal-sized ovarian veins actually had reflux, while some quite large ones were perfectly competent, meaning their valves worked fine.
So size isn't everything.
Not at all. This really highlights that relying solely on radiological findings like vein diameter to diagnose NCS can be misleading. The clinical picture of the patient's symptoms is really paramount.
You can't just look at the scan.
No. Just seeing a big vein on a scan doesn't automatically point to the Nutcracker as the culprit for pelvic symptoms. You need the whole story.
So what specifically causes that SMA to clamp down on the LRV and anterior NCS? Is it just bad luck with anatomy?
Well, while bad luck might feel like the answer sometimes, anatomically, there are a few key factors we look for. One is a more acute angle between the aorta and the SMA.
A sharper angle.
Exactly.
Yeah.
Normally it's around 35 to 40 degrees, but in NCS it's often less than 16 degrees. Think of it like kinking a garden hose. If it's sharply kinked, the flow is restricted.
Right.
This sharper angle can often be linked to a lack of retroperitoneal or mesenteric fat, which normally provides some cushioning between the vessels.
Less padding.
Yes. As well as wasting of the paraspinal muscles along the spine, and significant weight loss can also contribute.
So losing weight could potentially trigger it.
It's thought to be a factor in some cases, yes, by reducing that fatty cushion. However, different imaging studies have suggested slightly different angle cutoffs. MRA studies suggested less than 35 degrees, while CT findings correlated with venography pointed to less than 39 degrees, having high sensitivity and specificity for symptomatic NCS.
So doctors are looking for these specific measurements on scans, kind of like thresholds.
Yes, they're looking for these angles and ratios that might suggest the vein is getting squeezed enough to potentially cause problems.
That lack of fat makes sense, less padding for the vein. What about those with a thinner build generally? Does that connect?
Exactly. The observation that NCS is often seen in individuals with a particularly thin body habitus aligns perfectly with this idea of paucity or lack of retroperitoneal fat.
Okay. Any other causes?
Another potential cause that's been suggested is posterioroscosis of the left kidney.
Pitosis, like drooping.
Yes, drooping or sagging of the left kidney. This could potentially lead to abnormal angulation and stretching of the LRV as it enters the IVC, causing it to narrow and increasing the pressure inside. And there are also less common anatomical variants like an aberrant or unusual branching pattern of the SMA or an abnormal, particularly upward course of the LRV that can contribute to anterior NCS.
So sometimes it's not just the angle, but the specific way the vessels are formed or positioned.
Precisely. Lots of potential anatomical contributors.
We focused a lot on the front, on anterior NCS. What about the posterior version? Is that a completely different ballgame?
Interestingly, while studies suggest that the prevalence of posterior NCP, that's the retroaortic LRV without symptoms, might be similar to anterior NCP.
Okay.
There are far fewer reported cases of symptomatic posterior NCS and its management in the medical literature.
So less common to cause trouble?
It seems so. However, the symptoms that these patients do experience are reported to be similar to those with anterior NCS flank pain, hematuria. In reality, a retroaortic LRV itself is still considered an uncommon anatomical finding. Recent studies show a prevalence of maybe around 0.77% to 3.18%.
So less than 1 to about 3% of people.
Yeah, and only a small percentage of those cases, maybe around 6.5%, actually become symptomatic and develop posterior NCS.
Okay.
Because it's less common, there's just less data on the best ways to manage it compared to the anterior type. It's like a less common variation on the same thing.
And you can even have a combination of both, can't you? Sort of double whammy.
You can, yes.
Yeah.
This happens with a rare anatomical variant called a circumaortic renal vein.
Circumaortic, around the aorta.
Exactly. The LRV is duplicated, with one segment passing in front of the aorta and another segment passing behind it.
Wow.
This means both segments can be prone to compression, the anterior one by the aorta and SMA, and the posterior one by the aorta and the vertebral column.
So they can get squeezed from both sides.
Potentially, yes, leading to symptoms due to LRV hypertension and/or gonadal vein reflux. And finally, although extremely rare, right-sided NCS is also possible, often associated with that left-sided inferior vena cava we mentioned and other specific venous anomalies.
It just goes to show how much anatomical variation can occur.
It really does.
So a real spectrum of anatomical possibilities there. Now, we've talked about the anatomy and who might be affected. How does this actually present in terms of symptoms? What would make someone suspect they might have Nutcracker syndrome?
This is a key area where the understanding is still evolving, particularly in explaining why some people with the anatomical LRV compression develop symptoms while others don't.
Right, the phenomenon versus syndrome question again.
Exactly. The fact that NCP exists without symptoms and that the LRV can sometimes be stretched or even tied off in other conditions without causing NCS really raises questions about the exact physiological mechanism.
So why do some people get symptoms?
Well, hypotheses include things like a possible genetic predisposition to weaker venous walls. Maybe the vein wall itself isn't as strong in some people. And also the different time frames over which collateral veins, those detour pathways, can develop in NCS compared to more acute situations like a sudden injury or surgery.
So maybe the body doesn't adapt as well if it happens slowly.
That's one thought. It's somewhat similar to how May-Thurner syndrome, another venous compression issue, but in the leg veins, can sometimes be found incidentally on scans without causing any problems.
Right.
So maybe some people's veins are just more resilient, or perhaps their bodies are simply better at developing those collateral routes for blood flow to bypass the compression.
So maybe some people are just more susceptible or have less robust collateral pathways. That seems plausible.
That's a strong possibility.
Yeah.
Generally, the symptoms we see in NCS seem to correlate with two main hemodynamic issues.
Hemodynamic meaning related to blood flow and pressure.
Exactly. The first is hypertension, or high pressure,
Yeah.
in the left renal vein itself, leading to kidney-related problems. The second is the gonadal vein reflux caused by this hypertension, which then leads to pelvic venous disorders.
Okay.
As we discussed earlier, the LRV plays a vital role in pelvic venous drainage, connecting with the gonadal and iliac veins, with frequent cross-pelvic flow naturally.
Right.
So as LRV compression progresses and those pelvic collaterals form, you can start to see symptoms related to pelvic congestion syndrome emerging.
So if the blood flow gets backed up, where does it go? That's where this pelvic congestion syndrome comes in, right? It's like the overflow from the squeezed vein causing problems down in the pelvis.
Precisely. That backlog finds its way into the pelvic veins.
And these symptoms can be quite varied, I understand. Not always straightforward.
They can be very varied. The traditional constellation of signs and symptoms associated with NCS is actually quite variable, which is a major reason for diagnostic uncertainty and delays in getting diagnosed.
What are the most common ones then?
Historically, the most commonly reported symptoms have been left flank pain, often described as a dull or aching pain on the left side. Okay. Coupled with hematuria, that blood in the urine, which can be either visible to the naked eye, gross hematuria, or only detectable under a microscopic hematuria.
Right.
Then, as the LRV compression becomes more significant and those pelvic collateral veins develop and potentially become congested, you might start to see symptoms more typical of PCS.
Like what?
Things such as pain during intercourse, which is called dyspareunia, painful urination or dysuria, and/or painful periods, dysmenorrhea, in women.
So a range of pelvic symptoms, too. It's almost like everyone experiences this squeeze a little differently.
That's a very good way to put it. The presentation is highly individual.
What about physical exam findings? Is there anything a doctor might notice during an examination that could point towards NCS?
Yes, potentially. Physical exam findings can include varicose veins, not just in the legs, but sometimes in the lower extremities, the back of the thigh, and even the buttocks. In men, A left-sided varicocele that's a swelling of veins in the scrotum, often described as feeling like a bag of worms, can be present. It's typically on the left because the left gonadal vein drains into the left renal vein.
Ah, makes sense. And in women?
In women, vulvar or labial varices, varicose veins on the external genitalia might be noticeable.
But are any of these definitive?
No, that's important to stress. No single physical exam finding is definitive or pathognomonic for NCS. However, if you see a combination of these findings, especially along with hematuria and flank pain, it becomes strongly suggestive of the possibility of NCS.
So it's like putting puzzle pieces together.
Exactly. You're building a clinical picture.
Let's dig a bit deeper into hematuria, as that seems to be a really key symptom. What's the connection there? How does the squeeze lead to blood in the urine?
Hematuria is indeed the most commonly reported symptom. It often triggers a whole workup looking for urological causes of bleeding, like kidney stones or tumors.
Right, ruling out the more common stuff.
Exactly. And as we mentioned, microscopic hematuria is far more frequent than gross, visible hematuria. Some reports even describe hematuria being isolated just to the left ureteral orifice, the opening where urine from the left kidney enters the bladder. You might see that during a cystoscopy.
Okay, but why does it bleed?
The exact reason isn't fully definitively understood, but the prevailing theory revolves around that obstruction of blood flow out of the LRV, leading to increased pressure within the vein, LRV hypertension.
Okay.
This high pressure is thought to cause red blood cells and proteins to leak across the kidney's filtering units, the glomeruli, into the urine.
Ah, like forcing them through.
Kind of. Additionally, it's believed that this high pressure can lead to the development of thin-walled, fragile varices or collateral veins within the kidney's collecting system. These veins lack proper valves and are prone to rupturing, causing either microscopic or macroscopic bleeding into the urine.
So the backup pressure creates weak spots that can break.
That's the idea. There's also the possibility of dilated venous sinuses within the kidney communicating directly with the renal calyces, the funnels that collect urine. So multiple potential pathways for that squeezed vein to ultimately lead to blood appearing in the urine.
That's quite a few potential pathways for blood to end up where it shouldn't be. Are there any other less common but still notable symptoms associated with NCS?
Yes, orthostatic proteinuria has also been described as a common finding.
Orthostatic proteinuria. What's that?
That's the presence of protein in the urine, specifically when someone is standing or upright, but it disappears when they lie down.
Huh, interesting. Why would that happen?
The thinking is that the upright position might worsen the venous compression and hypertension, leading to more protein leakage. And there was a time, maybe less emphasized now, when NCS was thought to be linked to chronic fatigue syndrome in children, although that connection isn't as strongly supported today.
Okay. And the pain. Is it just from the pressure?
The pain associated with NCS, typically felt in the left flank, is often attributed to the passage of small blood clots formed due to the bleeding through the urinary collecting system. That can be quite painful.
Ouch.
However, it's worth noting that left flank pain can also be a symptom of something called gonadal vein syndrome, where the pain might radiate down the thigh and buttock. It just highlights again how symptoms can overlap and make diagnosis challenging.
It really sounds like there can be a lot of overlap in symptoms with other conditions, making diagnosis tricky. You mentioned the confusion with pelvic congestion syndrome earlier. Can you elaborate on that difference again?
Absolutely. While LRV compression, the Nutcracker anatomy, can definitely be a cause of PCS, it's important to distinguish between the two conditions conceptual.
Okay.
In PCS itself, the primary issue is the accumulation of blood and pressure in the pelvic veins due to reflux, backward flow, or obstruction in various pelvic or ovarian veins, leading to chronic pelvic pain and those perineal or vulvar varices.
Yeah.
The pain in classic PCS typically manifests as dyspareunia, painful intercourse, dysmenorrhea, painful periods, and or dysuria, painful urination. These are generally less common as the primary symptoms in classic NCS, which tends to present more with flank pain and hematuria initially.
So the main location of the pain might differ.
Often, yes, or at least the primary presenting symptoms might differ. However, symptoms like scrotal or vulvar varices and the associated pain, those can be exacerbated by standing, physical activity, or just being upright in both conditions.
Why is that?
Because being upright increases the gravitational pressure, increasing venous filling and distension of those already overloaded collateral drainage pathways in the pelvis and groin.
Makes sense. Gravity works against it.
Exactly. And interestingly, a 2018 study found that a significant percentage, over 28% of patients who presented with testicular varicoceles, were found to have coexisting NCS on further investigation.
Wow, more than a quarter.
Yeah, so it suggests a potential interplay and highlights the need to think about NCS when evaluating conditions like left-sided varicoceles. It's like having that traffic jam on the main road, LRV, causing the gridlock on the side streets, gonadal pelvic veins.
That really clarifies the connection. Okay, so if someone presents with these kinds of symptoms, flank pain, hematuria, maybe pelvic issues, varices, what's the next step in figuring out if it's actually Nutcracker syndrome? What kind of imaging is typically done?
Right. If there's clinical suspicion of LRV compression, imaging becomes essential. Primarily, you need to rule out other non-vascular causes of compression, like tumors we mentioned earlier. Those would require a completely different specialist and treatment plan.
Crucial first step.
Absolutely. And it's really crucial to emphasize again that while imaging is very helpful, the diagnosis and any treatment decisions for NCS should always be based on a careful consideration of the patient's clinical history and how their specific symptoms correlate with whatever the imaging findings show.
It's not just about the pictures.
No. Historically, multiple imaging studies were often obtained, but ultimately, venography was frequently considered the confirmatory diagnostic tool.
So imaging helps us see what's going on inside, but venography was the key.
Historically, yes. What made venography the sort of gold standard back then was its ability to directly measure the pressure gradient between the left renal vein and the inferior vena cava.
That renal caval pressure gradient you mentioned.
Exactly. That measurement can indicate if there's significant LRV hypertension or high pressure. Venography also provided a real-time assessment of blood flow and could directly show any reflux or backward flow into the gonadal and pelvic collateral veins.
You can actually see the blood going the wrong way.
Precisely. However, it's really important that the venogram technique is meticulous. If the contrast dye is injected too forcefully into the LRV,
Yes.
it can artificially create flow into the gonadal vein, which could be mistakenly interpreted as pathological reflux when it's just due to the high injection pressure.
So it could give a false positive.
Potentially, yes. Injecting contrast into the left renal artery instead, and then taking delayed images as it flows out through the veins, can be very helpful in avoiding this artifact.
Okay, so venography gave doctors direct information about the blood pressure and flow in those veins, but it sounds like there's been a shift away from that as the first-line test.
Yes, that's generally true. While some specialists might still favor initial left renal venography, non-invasive cross-sectional imaging modalities like CT and MRI have largely taken its place as the initial workup in most centers.
So CT and MRI come first now.
Often, yes. But it's important to understand that both catheter-based imaging like venography and cross-sectional imaging like CT-MRI provide different and often complementary pieces of the diagnostic puzzle. They aren't necessarily mutually exclusive.
They give us different perspectives on the problem.
Exactly.
Let's talk about ultrasound first then, as that's often the go-to for initial investigations in many areas. How useful is duplex ultrasonography, or DUS, in diagnosing NCS?
Duplex ultrasound is often the first imaging modality people turn to.
Right.
Because it's non-invasive, it doesn't involve any radiation, and it's widely available.
Right.
It can visualize the vascular anatomy, the aorta, SMA, renal vein, and give us basic information about blood flow, direction, and velocity within the LRV.
Can it show the compression?
It can, yes. It's particularly useful when performed by experienced practitioners, and it can sometimes show those characteristic gonadal and retroperitoneal collateral veins with reverse blood flow, flowing away from the LRV instead of towards it.
But you might not see those early on.
That's right. This finding might not be present early in the disease process, as those collateral pathways develop over time as a response to the chronic pressure.
Okay. Any downsides to ultrasound?
One of the main limitations of DUS is that relying on absolute LRV diameter measurements has been found to be pretty unreliable for diagnosis. There's just too much normal variation, and technical factors can affect the measurements.
So just measuring how wide the vein is doesn't really tell you much.
Not definitively, no. However, what can be very helpful is looking at the ratio between the diameters and the flow velocities in different parts of the vein.
How does that work?
You compare the measurement in the narrowed, compressed segment near the aorta SMA to the measurement in the dilated segment further out towards the kidney. A diameter ratio greater than 5.0 or a velocity ratio greater than 5.0 is considered suggestive of NCS, and has shown reasonably good sensitivity and specificity in some studies.
So it's the change along the vein that matters more.
Exactly. The degree of narrowing relative to the dilation. Another parameter sometimes used is the peak velocity in the vein after the narrowed segment if it's very high, say greater than 100 centimeters. That also suggests significant turbulence from the compression upstream.
Okay, so it's more about the change in flow and shape along the vein rather than just the absolute size. Are there any other drawbacks to using DOS?
Yes, there are potential pitfalls. Patient factors like their body habitus, if someone is very large or having a lot of overlying bowel gas, can make it technically difficult to get clear images of these deep vessels.
Right, things get in the way.
Exactly. There's also operator variability, meaning the accuracy can really depend on the skill and experience of the person performing and interpreting the ultrasound.
So you need someone who knows what they're looking for.
Definitely.
Yeah.
Also, the patient's positioning, whether they're lying flat or standing up, can also affect the measurements, because standing can sometimes change that angle between the aorta and SMA.
Mm-hmm.
And as we discussed, the diameter of the vessel can even fluctuate slightly during the cardiac cycle. So while DUS is often a good initial screening tool, it's usually used in conjunction with other cross-sectional imaging like CT or MRI to get a more complete and definitive picture.
Which brings us neatly to CT and MRI. What role do these play in diagnosing Nutcracker syndrome?
Axial imaging with either MRI or contrast-enhanced CT has become increasingly important in the initial workup for suspected NCS.
Axial meaning looking at slices across the body.
Yes, exactly. Both CT and MRI are quite useful in demonstrating that characteristic beak sign.
The beak
Yeah.
sign?
Yes, it's the visual appearance of the triangular narrowing of the LRV as it gets compressed between the SMA and aorta. It looks like a bird's beak on the cross-sectional images.
Oh, okay, I can picture that. What else can they show?
They can also clearly show the presence of a retroaortic or a circumaric LRV, which is important for surgical planning if needed. They're also crucial for ruling out those other causes of compression, like retroperitoneal masses or enlarged lymph nodes.
Right, the non-vascular causes.
Exactly. And they're very good at visualizing the pelvic and periaortic collateral veins, as well as dilation of the gonadal vessels, which are key signs of that venous hypertension.
And seeing those collaterals is important.
Critically important. The visualization of pelvic collaterals on these scans is very significant. If they aren't present, it makes NCS as the underlying cause of the patient's symptoms much less likely. It suggests the pressure maybe isn't high enough to force blood into those alternative routes.
So absence of collaterals argues against NCS.
Strongly argues against it being the cause of symptoms, yes. One study actually found that the beak sign on CT had the highest diagnostic accuracy compared to other CT-derived measurements like angles or ratios. Other studies have proposed specific cutoff values using CT with 3D reconstruction capabilities, such as an LRV diameter ratio comparing the wider part near the kidney, hilaric, to the compressed part, aortomesenteric, greater than 4.9, or that SMA aorta angle being less than 41 degrees.
So again, doctors are looking for these specific measurements on scans, these thresholds, that might suggest the vein is getting squeezed enough to cause problems.
Precisely. They're trying to quantify the degree of compression.
That's quite specific in terms of measurements. What about the correlation between the amount of compression seen on CT and the actual symptoms?
Well, a study by Hang and colleagues looked at CT and CTV, CT phonography, scans in patients both with and without diagnosed NCS. They found quite a strong correlation between the degree of LRV compression seen on the scan and the clinical diagnosis of NCS.
So more squeeze meant more likely to have NCS.
Generally, yes. They even established specific sensitivity and specificity values for different compression ratios, comparing the LRV diameter before compression to the diameter at the narrowest point. For example, a ratio greater than 2.25 or 3.0 was highly suggestive.
Interesting. Did they link the compression level to specific symptoms?
Yes, their analysis suggested that a higher degree of LRV compression was associated with having hematuria, proteinuria, that protein in the urine, loss, and general abdominal pain. But interestingly, not necessarily with left flank pain, specifically in their cohort.
Huh. So the link between the anatomy and the exact symptoms can still be complex.
Very much so.
An MRI, what does that offer in comparison to CT? Does it have advantages?
MRI can provide similar, very detailed anatomical information, but it has the advantage of doing so without using ionizing radiation like CT does.
That's a big plus, especially for younger patients.
Absolutely. Particularly if multiple imaging studies might be needed over time. MRI can also sometimes be performed without intravenous contrast agents, which is beneficial for patients with kidney problems or contrast allergies. And MRI can also give some insights into the obstruction of blood flow in the LRV using specific flow-sensitive sequences.
Can it diagnose NCS well?
Yes. A prospective study by Weir and colleagues, specifically in pediatric patients, show that a non-contract MRI sequence called T2 True Fast Imaging with steady-state free precession, quite a mouthful.
Uh-huh, yeah.
That sequence was valuable for both diagnosing NCS and also for following up with these patients after treatment or during observation.
Okay. But CT and MRI still don't give the pressure measurements, right?
Correct. It's important to remember that both CT and MRI are primarily anatomical assessments.
Oh.
They show us the structures very well, but they don't give us direct hemodynamic data, like that renocuval pressure gradient or the exact severity of reflux into the gonadal and pelvic veins.
So we're back to venography for that specific hemodynamic information, even if it's not usually the first-line test anymore. What exactly does venography tell us about the hemodynamics?
Right. Venography allows us to directly measure that crucial renocuval pressure gradient. This is often done using a pullback technique.
Pullback.
Yes, where a catheter with a pressure sensor is placed in the LRV, and pressure is measured continuously as the catheter is slowly pulled back across the compressed segment into the IVC. The difference in pressure is the gradient.
Okay.
Venography also lets us directly visualize that narrowing of the LRV caused by the aorta and SMA and anterior NCS, see the dilation of the LRV segment before the narrowing, and very importantly, see the reflux of contrast dye flowing backwards into those collateral pathways, the gonadal, lumbar, and adrenal veins.
You can see the whole network light up.
Exactly. And you might also observe sluggish, slow flow of contrast clearing from the LRV, indicating obstruction.
Now, you mentioned debate about the pressure gradient cutoff. What's considered abnormal?
Well, initial studies back in the day tried to establish a normal range, maybe 0 to 3 millimeter Hg, but subsequent studies challenged this, with some finding almost all normal individuals had a gradient less than 1 millimeter Hg.
So, quite low normally?
Yes. There's been a lot of debate about absolute cutoff values because there can be overlap between pressures measured in normal individuals and those with NCS. Some studies have found gradients of 3 to 10 millimeter Hg in normals, while NCS patients might range from 2 to 14 millimeter Hg or even higher.
So overlap makes it tricky.
It does. However, a gradient of 3 millimeter Hg or greater is often considered suggestive or diagnostic of significant LRV hypertension, especially when it's seen in combination with hematuria and the visualization of collateral veins filling with contrast on the venogram.
The whole picture again.
Exactly. It's also important to note that in very long-standing NCS, where extensive collateral veins have developed over years, the pressure gradient measured at rest might actually be lower, maybe even near normal, because those collaterals are effectively decompressing the LRV. The pressure might only become significantly elevated during exercise or certain maneuvers.
So a normal pressure doesn't rule it out completely in some cases?
Not necessarily, especially if the clinical picture and other imaging findings are highly suggestive. Also, factors like patient positioning during the measurement and their hydration level can potentially affect the pressure readings. So it's not always a single clear-cut number that gives you the answer.
It sounds like it's a really complex diagnostic picture with no single imaging modality giving all the answers definitively. What about some of the older imaging techniques? Are things like intravenous urography still used at all?
Not really. Historically, yes. Things like intravenous urography, IVU or IVP, retrograde pyelography, and IVC phlebography were sometimes used in the workup of hematuria or suspected venous issues, but they don't really have a primary role in diagnosing NCS today. They just don't provide the specific anatomical and hemodynamic information we can get from ultrasound, CT, MRI, and venography.
Okay. And cystoscopy, looking inside the bladder.
Cystoscopy is often performed, yes, but primarily as part of the standard workup for hematuria, mainly to rule out other causes like bladder tumors or stones.
Right.
It can sometimes help localize the bleeding to the left urethral orifice, which would be consistent with a left kidney source like NCS. But there are no specific cystoscopic findings that definitively say this is Nutcracker syndrome. So it's only indirectly helpful in the NCS diagnosis, mostly by excluding other possibilities.
Okay, so we've covered the background, the anatomy, the varied symptoms, and the complex diagnostic process. Now let's talk about what happens when someone is diagnosed with symptomatic Nutcracker syndrome. What are the management options?
Right. The primary goal of any treatment for NCS is fundamentally to reduce or ideally eliminate the hypertension, the high pressure in the left renal vein, and also address any resulting significant reflux into the gonadal vein if that's causing pelvic symptoms.
Makes sense. Relieve the pressure.
Exactly. While prompt diagnosis is important, the careful selection of which patients should undergo treatment and the specific surgical or endovascular strategy employed are absolutely critical for achieving good outcomes.
And is there agreement on who should be treated and how?
Unfortunately, no. Currently, there's still a significant lack of consensus within the medical community on exactly when intervention is warranted, which patients are the best candidates, and what the single optimal surgical or endovascular technique is.
So still evolving.
Very much so. It's really important to stress that just finding radiographic evidence of compression, seeing that bird beak appearance on a CT or MRI scan, is not usually enough by itself to warrant surgery or intervention.
You need more than just the picture.
Absolutely. Typically, you need the presence of significant bothersome symptoms, like persistent hematuria, especially if causing anemia, the clear visualization of collateral veins on imaging, indicating that pressure is indeed high, and often debilitating pelvic or flank pain to even consider intervention.
So the symptoms have to be significant.
Yes. Generally, these interventions aim to lower that high pressure in the LRV caused by the compression, but often the practical decision to proceed with treatment is driven by the patient experiencing debilitating pain that affects their quality of life or having gross hematuria that's significant enough to cause anemia.
So it really comes down to whether the squeeze is significantly impacting the person's life and health.
Precisely.
You mentioned conservative management earlier, particularly for kids. Can you expand on that? What does that entail, and for whom might that be a reasonable option?
Right. We haven't focused heavily on detailing conservative management because it's really most applicable and often recommended for children or adolescents who present mainly with hematuria and are found to have the anatomical features of NCS.
Why specifically kids?
The idea, or the hope, is that with further natural growth and potentially some weight gain as they mature,
Yes.
the angle between the aorta and the superior mesenteric artery can widen naturally. This can spontaneously relieve the LRV compression without needing any invasive procedures.
So they might literally grow out of it?
Potentially, yes. A 2019 systematic review looking at pediatric NCS cases supported this conservative approach, noting that a high percentage of young patients, particularly males in their series, saw resolution or significant improvement of their symptoms with just observation and conservative management over a period of time.
What does conservative management involve then? Just waiting.
It involves regular monitoring, often using ultrasound to track the aortomesenteric angle and LRV flow parameters. It also involves managing symptoms symptomatically, for example, iron supplements if there's anemia from hematuria, pain management if needed. More invasive tests like venography are usually reserved for cases where the ultrasound is inconclusive or symptoms are severe and persistent. So for most pediatric patients without persistent, severe symptoms like debilitating pain or significant anemia, a period of conservative treatment and observation is often the appropriate first-line strategy.
That makes sense, letting nature potentially take its course first. But for adults or kids with severe persistent symptoms, surgical or other intervention is often considered. What are the open surgical options for the more common anterior nutcracker syndrome?
Right. For adults or those with severe symptoms where observation isn't appropriate, intervention is often the next step. And historically, open surgery has been the mainstay. There are actually quite a few different open surgical techniques that have been described and used over the years for anterior NCS.
What are some of them?
The list includes things like moving the LRV to a different position on the IVC, which is called LRV transposition, sometimes with the addition of a patch of vein material to widen the connection. Patch venoplasty.
Oh.
You can also do just patch venoplasty alone. Another option is moving the gonadal vein and connecting that to the IVC or the iliac vein instead, or creating a bypass using a vein taken from the leg, usually the saphenous vein. That's a saphenous vein bypass.
Wow, lots of options.
There are even more complex procedures like left renal autotransplantation, where the kidney is removed, flushed, and then reimplanted lower down, connecting the vein to the iliac vein. And in very rare extreme cases, nephrectomy actually removing the affected kidney has been done, although that's highly undesirable.
Yeah, you want to save the kidney if possible.
Absolutely. There have also been attempts at placing external stents or bands around the LRV to hold it open, and even a procedure called nephropexy, which aims to lift a drooping kidney to potentially relieve tension on the vein. But we'll focus on the most commonly performed techniques.
Okay.
Essentially, all these open surgeries aim to achieve one of two things: either physically move the vein out of the nutcracker jaws, or create a new, unobstructed pathway for the blood to flow out of the left kidney and back to the heart.
Let's start with the one that seems most frequently reported. LRV transposition. How is that actually done, moving the renal vein?
Right. LRV transposition typically involves a transabdominal approach,
Mm-hmm.
meaning surgery through the abdomen, usually via midline or a transverse incision. The small bowel is gently retracted or moved aside to get access to the retroperitoneum, where the major vessels lie.
Okay.
The surgeon then carefully mobilizes the left renal vein, freeing it up from surrounding tissues. This often requires ligating, tying off, and dividing the veins that normally drain into it, like the left gonadal vein, the left adrenal vein, and sometimes one or more lumbar veins.
So you have to disconnect its tributaries.
Yes, to get enough length and mobility. After giving systemic heparin, a blood thinner, to prevent clots, the surgeon temporarily clamps the inferior vena cava above and below where the LRV joins it. Then the LRV is transected, or cut, very close to its original entry point into the IVC. The vein is then moved downwards, or caudally, and reimplanted into the side of the IVC at a lower position, creating a new connection, an end-to-side anastomosis that is free from compression by the SMA.
And the old hole in the IVC.
The original opening in the IVC where the LRV used to be is then closed with sutures.
Okay. You mentioned sometimes using a patch.
Yes. In some cases, especially in long-standing NCS, where the LRV itself might have become somewhat narrowed, fibrotic, or distorted due to the chronic compression,
Right.
a patch made from the patient's own saphenous vein taken from the leg, or sometimes a cuff of saphenous vein, might be used during the transposition. This helps to ensure a wider opening, a spatulated anastomosis, and a tension-free connection at the new site.
Why use the saphenous vein?
The saphenous vein is often preferred because it's usually readily available, especially in this typically younger patient population. It's the patient's own tissue, so less risk of rejection, and it generally has a lower risk of infection compared to using synthetic patch materials.
So it's a bit like rerouting a kinked pipe and maybe widening the connection point.
That's a good way to think about it, yes. Rerouting the vein to avoid the squeeze.
What about just patching the vein without actually moving it? Is that ever done?
Patch venoplasty alone, without transposing the LRV, is a less commonly performed option. It might be considered in situations where the LRV is unusually short or maybe seems overstretched already.
Overstretched? How?
Well, perhaps due to a very prominent bulging aorta or maybe a very low-lying tonic kidney. In these scenarios, simply moving the vein might not fully relieve the compression or could create tension. So a patch might be used to widen the compressed segment in its original location.
Okay.
Also, in cases where doing the LRV transposition would create too much tension on the new connection point on the IVC, surgeons might use a cuff of saphenous vein attached directly to the IDC first, and then sew the transposed LRV to that cuff, effectively lengthening it to achieve a tension-free anastomosis.
So different ways to ensure a good open connection.
Exactly. It's about finding the most effective and safest way to relieve that pressure for the individual patient's anatomy.
Another technique you mentioned was gonadal vein transposition. That sounds quite different from moving the main renal vein.
It's quite different conceptually, yes. Gonadal vein transposition can be a very feasible and sometimes maybe even the only practical surgical option, particularly in cases of posterior NCS or some atypical forms.
What are the advantages?
One of its key advantages is that by using the gonadal vein as the new outflow, it inherently treats any associated gonadal vein reflux that might be contributing to pelvic congestion symptoms.
So it addresses two problems at once.
Potentially, yes.
Yeah.
It also avoids the need to clamp or cut the main renal vein itself, which theoretically reduces the risk of thrombosis or stenosis at the anastomosis site. It typically requires only a single new connection, the gonadal vein to the IVC, and it avoids the need for a separate leg incision to harvest a saphenous vein.
Sounds good. Are there requirements for it to work?
Yes, there are crucial requirements. For this technique to be effective, the gonadal vein needs to be large enough in diameter. Ideally, its diameter should be at least 75% of the LRV's diameter to be able to adequately decompress the high pressure from the LRV.
So it has to be a big enough pipe.
Exactly. And the segment of the gonadal vein before it starts branching out in the pelvis needs to be long enough to reach the IVC without any tension when it's transposed.
How do you know if it's suitable?
These factors, the size and length, are usually assessed with preoperative imaging like CT or MRI venography, and then confirmed visually during the operation itself.
So instead of moving the main renal vein, you're essentially using one of its major tributaries, the gonadal vein, as a new primary outflow route to the IVC.
That's precisely the concept.
How is the gonadal vein transposition procedure actually performed then?
It's usually done through a similar transabdominal incision, though sometimes a smaller one might suffice. The surgeon identifies and carefully mobilizes the gonadal vein in the retroperitoneum, ligating any smaller side branches to maximize the usable length. The vein is then cut distally, down in the pelvis near the iliac vessels. It's then carefully tunneled, usually posterior to the inferior mesenteric vein, up towards the IVC.
Right.
After administering heparin and applying a partial occlusion clamp to the side of the IVC, so blood flow continues through the main IVC, the proximal end of the mobilized gonadal vein is controlled and then anastomosed or sewn end to side directly to the IVC below the level of the renal veins.
Creating the new connection.
Yes. After the anastomosis is complete, the clamps are released and blood flow through the newly transposed gonadal vein is confirmed, often using intraoperative Doppler ultrasound.
And post-op.
Postoperatively, we typically recommend a short course of intravenous heparin followed by oral anticoagulation like warfarin or a newer agent for about 30 days, and then possibly lifelong low-dose aspirin, although the evidence for the aspirin is less strong.
You mentioned this is preferred at your institution?
Yes. At our institution, gonadal vein transposition has actually become our preferred open surgical strategy for NCS when the anatomy is suitable. We favor it because of its potential advantages,
Which are?
including generally a less extensive dissection compared to LRV transposition, no need for manipulation of the LRV itself, which might reduce risks like thrombosis or stenosis, no leg incision, usually only a single anastomosis, and our experience suggests good overall outcomes with potentially decreased morbidity and shorter hospital stays compared to LRV transposition.
And the results bear that out.
The largest published case series on this technique actually comes from our center. It showed that in appropriately selected patients, gonadal vein transposition was safe and effective in relieving symptoms for the majority of patients, with no major complications during the follow-up period. So for us, it's become our go-to approach for the right anatomical fit.
That sounds like a really good, less invasive open option in the right patients. You also briefly mentioned saphenous vein bypass. When would that be used instead?
Saphenous vein bypass is generally reserved for those less frequent situations where neither LRV transposition or gonadal vein transposition is technically feasible or considered optimal, perhaps for either anterior or posterior NCS.
So like a third option.
Exactly. As the name suggests, it involves harvesting a segment of the patient's saphenous vein from their leg and using it to create a new conduit, a bypass graft, for blood to flow from the dilated part of the LRV directly to the IVC, completely bypassing the compressed segment.
What are the downsides?
Well, this procedure does require the separate leg incision to harvest the saphenous vein. It also requires creating two anastomoses, one connecting the graft to the LRV and another connecting it to the IVC, and it still necessitates temporarily clamping the LRV during the procedure, so it's a bit more involved in some ways.
It's like building a whole new detour around the traffic jam rather than just rerouting an existing road.
That's a perfect analogy, yes.
And what about minimally invasive techniques for open surgery? You mentioned robotic-assisted surgery earlier. Is that becoming common?
Yes. Robotic-assisted LRV transposition is a newer technique that's emerging and certainly shows some initial promise in case reports and small series. But the evidence base is currently quite limited, so more extensive studies comparing it to traditional open surgery are definitely needed before it becomes mainstream.
What are the potential benefits of using the robot?
The theoretical or purported benefits include things like increased range of motion for the surgical instruments inside the body compared to standard laparoscopy, enhanced 3D visualization of the surgical field for the surgeon, and potentially improved surgeon ergonomics and comfort during a long, delicate procedure.
So it's leveraging technology to potentially make a complex open surgery a bit easier or more precise for the surgeon.
That's the hope, yes. But whether it translates to significantly better patient outcomes is still being evaluated.
So a lot of different open surgical options available for anterior NCS. What are the typical outcomes like overall? Is the surgery generally successful?
Overall, the outcomes reported with open surgery for anterior NCS are generally considered clinically acceptable, meaning they usually help patients. One of the larger studies we can look at is a retrospective review from the Mayo Clinic. They primarily used LRV transposition as their first-line surgical approach.
What did they find?
They reported an average hospital stay of around 4.5 days, which isn't too long. At long-term follow-up, they saw a recurrence of significant symptoms in about 8% of patients.
Okay, relatively low recurrence. Any issues with the repair itself?
Well, they did find that around 22% of patients required some kind of further intervention later on, either endovascular, like angioplasty or stenting, or repeat open surgery, usually due to stenosis, narrowing, or occlusion blockage of the transposed vein or the anastomosis site.
So nearly a quarter needed something else done eventually.
Yes, that's something to consider. However, the good news from their study was that specifically adding a saphenous vein patch or cuff during the initial transposition seemed to significantly improve the long-term patency, meaning how well the reconstructed vein stayed open over time.
So that patch makes a difference.
It appeared to in their series. They also reported no major immediate perioperative complications like death or kidney failure requiring dialysis.
That's very good news.
Absolutely. Other less common postoperative complications that can occur after these types of major retroperitoneal surgeries include things like deep vein thrombosis, DVT, or blood clots in the legs, bleeding in the retroperitoneal space, hematoma, temporary paralysis of the bowel, paralytic ileus, and occasionally something called chylous ascites, which is a leakage of lymphatic fluid into the abdomen.
But life-threatening complications are rare.
Yes, the risk of death during or shortly after surgery for NCS is exceedingly low, based on reported series.
And anticoagulation after surgery.
Postoperatively, we typically recommend a course of therapeutic anticoagulation, usually with newer oral anticoagulants, NOACs or warfarin, for about 30 days to prevent clots in the newly reconstructed vein. There might also be some theoretical benefit from adding antiplatelet medications like aspirin long-term, but the evidence supporting that is not yet very strong.
So generally, open surgery can be quite effective for anterior NCS, providing symptom relief for most. But like any major surgery, it comes with potential risks and the possibility of needing further procedures down the line.
That's a fair summary, yes.
That sounds generally encouraging for open surgical repair of anterior NCS. Now, what about the posterior version? You said open surgery for that is more challenging. Why is that?
Yes, open surgery for posterior NCS, where the LRV runs behind the aorta, can definitely be more technically challenging.
How so?
Well, because the LRV is already positioned behind the aorta, performing a standard LRV transposition would require mobilizing it extensively and bringing it all the way around to the front of the aorta to connect it to the IVC anteriorly.
That sounds difficult.
It is. The dissection required in that very narrow space between the patient's vertebral column and the back wall of the aorta carries a significantly higher risk of inadvertently injuring important structures back there, like lumbar arteries and veins, perirenal vessels, and other crucial collateral veins.
Some more delicate dissection needed.
Very much so. There's also the potential for damaging lymphatic vessels that run along the aorta, which can lead to problematic postoperative lymphatic fluid leaks or chylous ascites.
Okay.
Similar to anterior LRV transposition, if the posterior LRV has been chronically compressed, a vein patch might be needed during the transposition, adding complexity. And the retroaortic LRV itself is often described as being quite thin-walled and potentially more fragile or friable than a normal anterior LRV, making it more susceptible to injury during surgical manipulation.
So higher risk all around. What about minimally invasive for posterior?
While laparoscopic or keyhole techniques have been described for posterior NCS transposition, they are generally not recommended for routine use. It requires an extremely high level of advanced laparoscopic surgical skill to perform that delicate venous anastomosis safely and effectively in such a confined space using minimally invasive tools.
So open surgery remains the more common approach for posterior NCS when intervention is needed, is that right?
Yes. According to a 2018 systematic review that specifically looked at the management of posterior NCS, open surgery is still the most frequently utilized treatment option when intervention is indicated.
But the data is limited.
Exactly. The review emphasized that the overall data are quite limited because symptomatic posterior NCS is much less common than the anterior form. So most of the available evidence comes from just a small number of cases reported in the literature, and the findings need to be interpreted cautiously.
Are there other open options for posterior NCS besides transposition?
Yes, other open surgical strategies that have been reported for posterior NCS include saphenous vein bypass, creating a detour graft,
Right.
very rarely, moving the aorta itself, aortic transposition, which is a huge operation, and importantly, gonadal vein transposition is also an option here.
Ah, so gonadal vein transposition can work for posterior too.
Yes, and potentially very well. As with anterior NCS, when it's technically feasible, based on the gonadal vein size and length, gonadal vein transposition can often avoid many of the specific risks associated with dissecting directly around the retroaortic renal vein itself. This can be particularly advantageous in these challenging posterior cases.
And the approach is the same.
The surgical approach for performing gonadal vein transposition in posterior NCS is essentially the same as for anterior NCS, connecting the mobilized gonadal vein to the IVC.
Okay. And complications.
The potential complications for open posterior NCS treatment are generally similar to those listed for anterior NCS repair.
So to sum up posterior NCS surgery.
Well, while the anatomical variant of a retroaortic renal vein might be encountered more frequently on imaging than we initially thought, truly symptomatic posterior NCS requiring treatment remains relatively rare. As a result, the reported experience with its management is mostly limited to case reports and small institutional series. This leads to a lack of robust long-term follow-up data and, consequently, no real consensus yet on the single optimal treatment strategy.
It's a rarer problem with less established solutions compared to the anterior type.
That's a good way to summarize it, yes.
Okay, we've covered the open surgical routes pretty thoroughly. What about less invasive endovascular treatments for Nutcracker syndrome? I know stenting has been used for other vascular compression syndromes like May-Thurner in the leg. Has that been tried for NCS?
Yes, absolutely. Endovascular treatment, which primarily involves the placement of a metallic stent inside the compressed segment of the left renal vein to hold it open, has been proposed and utilized for NCS.
How successful has it been?
Well, similar to its use in other venous compression syndromes like thoracic outlet syndrome involving the subclavian vein or May-Thurner syndrome involving the iliac vein, the success with LRV stenting for NCS has been somewhat limited or debated, particularly regarding long-term durability and potential complications.
When was it first tried?
The first description of using an endovascular stent for NCS was published back in 1996 by Nest and colleagues. For a long time after that, most of the available data consisted mainly of isolated case reports or very small series. However, more recently, larger series looking at the outcomes of LRV stenting have started to emerge.
What do these larger series show?
One study by Wang and colleagues reported on 30 NCS patients who underwent LRV stenting. They found symptomatic improvement in all patients at a median follow-up of 3 years, which sounds promising.
Any catches?
Well, they did note 2 cases where the stent appeared to protrude slightly into the inferior vena cava, which were managed just with close monitoring. So it's a less invasive option, yes, but clearly not entirely without its own set of potential issues.
Stent protrusion sounds a bit concerning, even if monitored. Have there been other, maybe more serious complications reported with endovascular stenting for NCS?
Indeed, there have been. A larger series, published by Chen and colleagues, looked at 61 patients who underwent LRV stenting. They also reported generally positive outcomes in terms of technical success, getting the stent in, and symptom resolution or improvement at a median follow-up of 66 months, with a relatively low rate of complications during or shortly after the procedure.
But
They did experience some significant complications. These included things like improper stent deployment requiring conversion to open surgery during the initial procedure, and perhaps most worryingly, a case of stent migration, where the entire stent dislodged and traveled through the bloodstream to the right atrium of the heart.
wow, to the heart, that's serious.
Extremely serious. That patient required emergency open heart surgery to retrieve the migrated stent.
Goodness, what causes a stent to migrate like that?
While the authors of that study emphasized the importance of using stents with specific properties for this location, high radial strength to resist the compression, good flexibility or conformability to adapt to the vein shape, and minimal shortening after deployment to ensure accurate positioning. They also suggested that the risk of migration might be a key issue.
Has migration been seen in other studies too?
Yes. In fact, the risk of stent migration has led some experts to recommend deliberately oversizing the stent diameter slightly relative to the vein, and also positioning the stent so that its proximal end extends slightly into the first major division or branch of the LRV, hoping to provide better anchoring.
Does that work?
It's debated. Worryingly, more recent, larger studies with longer follow-up periods, often using an endovascular first strategy for treating NCS, have actually shown a higher stent migration rate, reported around 6.7% in one large series, than was perhaps initially appreciated from the earlier, smaller reports.
Wow, stent migration sounds pretty serious. How often does that actually happen, and what are the long-term consequences? That 6.7% rate gives you an idea. The consequences can be significant, as that migrated stent usually needs to be retrieved, often invasively.
It is a major concern. These migrated stents have been reported to travel to various locations, into the main IVC, back into the proximal LRV itself, and, most alarmingly, into the right atrium or right ventricle of the heart, sometimes necessitating that complex open cardiac surgery for retrieval. They could potentially even travel to the lungs, causing a pulmonary embolism.
That's frightening. Can doctors predict who is at risk for migration?
It's difficult. Interestingly, some studies haven't found statistically significant differences in the anatomical measurements or the measured hemodynamic pressure gradients between patients whose stents migrated and those whose didn't. However, some authors strongly suggest that the diameter of the stent chosen is a key factor, noting the specific sizes of the stents that migrated in their series.
So maybe choosing the wrong size?
That's a leading theory. This really underscores the critical need for venous stents that are specifically designed and approved for use in the unique environment of the renal veins, rather than just repurposing stents designed for arteries or other veins.
Right. Given the potential for these stents to travel to the right side of the heart or the lungs, those reported migration rates are definitely quite concerning. What types of stents have typically been used?
The types of stents used in most of these published NCS studies have predominantly been self-expanding metallic stents, often designs originally intended for biliary use or peripheral arteries.
Okay. Any other complications besides migration?
Yes, other potential complications associated with LRV stenting include the formation of blood clots within the stent itself, known as in-stent thrombosis or stenosis.
Which could block it off again.
Exactly. And also, though less common, stent fracture, where the metal mesh of the stent actually breaks over time due to the constant forces in that area.
And the protrusion into the IVC, is that always bad?
Interestingly, some authors consider minor stent protrusion from the LRV into the IVC to be relatively safe, and perhaps even necessary sometimes, to ensure the opening of the renal vein is fully covered. But significant protrusion is generally avoided.
And like other stents, patients need medication afterwards.
Yes, absolutely.
Hmm.
As with most arterial and venous stenting procedures, postoperative antiplatelet medications, like aspirin and or clopidogrel, are considered essential to minimize the risk of those potentially devastating blood clots forming on the stent surface.
So while endovascular stenting offers a clearly less invasive initial procedure compared to open surgery, the risk of stent migration seems to be a major, serious concern that tempers enthusiasm a bit.
That's a very accurate summary of the current situation, yes.
What about the long-term outcomes of stenting compared to open surgery? Does the fix last?
That's another key question. While some studies, particularly those from centers advocating an endovascular-first approach, report adequate long-term symptom relief and patency rates with stenting,
Yeah.
a significant limitation in the current literature is the glaring lack of direct, head-to-head comparative studies looking at open versus endovascular therapy for NCS, performed during the same time period at the same institution with similar patient selection criteria.
So we can't directly compare apples to apples?
Not really, no. This makes it very difficult to definitively assess the true long-term durability of the endovascular approach compared to the established open surgical repair.
Okay. And the stents themselves?
As we touched upon, another issue is that the majority of stents used for LRV compression so far were originally designed for the structure and flow dynamics of arteries, which are quite different from veins. Veins are lower pressure, have thinner walls, and are more prone to external compression.
Right.
And considering that NCS often affects younger individuals, the potential need for lifelong imaging follow-up after placing a permanent metal implant like a stent is also a factor that needs to be discussed with patients.
So long-term surveillance is needed. But is there hope for improvement?
Yes, there is optimism. The field of venous stenting is rapidly evolving, driven largely by the increasing development and use of dedicated venous stents for treating other chronic venous conditions, particularly iliac vein compression, like May-Thurner, and post-thrombotic syndrome.
So stents made specifically for veins are becoming available.
Exactly. As these dedicated venous stents become more widely available and tested, the hope is that their use might eventually translate to improved safety, especially regarding that critical issue of migration risk and potentially better long-term clinical outcomes for the endovascular treatment of NCS as well.
So the technology is evolving, and maybe in the future, stenting could become a more reliable and safer alternative to open surgery.
That's certainly the hope and the direction things seem to be heading. It might eventually become a suitable first-line alternative for many patients, but we're not quite there yet in terms of having the definitive long-term data and optimized technology for this specific location.
Okay. Finally, you mentioned a hybrid approach very briefly. What does that involve? Is that common?
The hybrid approach is really an emerging concept in NCS management. It involves combining elements of both open surgical techniques and endovascular techniques in the same patient, often during the same procedure.
How would that work?
For example, a surgeon might perform an open transposition, but find the vein is still narrowed, so they place a stent across the anastomosis. Or they might use an endovascular approach to place a stent, but need an open procedure to deal with large collateral veins.
Interesting. Is it promising?
While some initial reports sound promising, the number of patients who have actually been treated with these kinds of combined hybrid methods is still very, very small. So we really need much more experience and larger studies to draw any firm conclusions about the feasibility, safety, and overall effectiveness of these hybrid strategies. The very niche area right now is still experimental.
Got it. Still very early days for the hybrid approach. Okay, it sounds like the management of Nutcracker syndrome is truly a field with a lot of evolution, ongoing research, and still some significant unanswered questions. Let's try to summarize some of the key takeaways from our deep dive before we wrap up.
Absolutely. I think the first key point is that the management of NCS is definitely still evolving. It's a condition that can cause significant lifestyle-limiting morbidity problems like chronic pain, recurrent hematuria, sometimes leading to anemia, and even disfiguring varices in the pelvis or legs.
Right, and it's caused by that squeeze.
It's fundamentally a result of the left renal vein being compressed, usually between the aorta and SMA, or sometimes stretched. And we're still really speculating and learning about why only some individuals with this anatomical compromise actually develop the symptoms of the syndrome, while many others remain completely asymptomatic.
The phenomenon versus syndrome mystery.
Exactly. NCS is also a condition that's often misdiagnosed or diagnosed late, sometimes only after symptomatic renal venous hypertension has been present for a long time, potentially making repair more complex.
And diagnosis isn't simple?
No, there's no single gold standard diagnostic test. But usually, an efficient diagnosis can be made through a combination of a careful clinical evaluation, recognizing the characteristic constellation of symptoms and correlating those with the findings on appropriate imaging, usually cross-sectional imaging like CT or MRI, sometimes supplemented by duplex ultrasound and, in select cases, invasive venography with pressure measurements.
And the decision to treat.
The decision to intervene, to actually treat the NCS, is really based on a synthesis of the clinical presentation. How bad are the symptoms? The confirmatory radiologic findings. Do the images match the symptoms? And importantly, the individual patient's preferences and goals after a thorough discussion of the risks and benefits of the different options.
And if treatment is shown.
There are a variety of applicable surgical and endovascular strategies, as we've discussed. The best choice is often dictated by the specific subtype of NCS, anterior, posterior, etc., the patient's individual anatomy found intraoperatively or on detailed imaging, and the surgeon's or interventionist's experience and expertise.
And does treatment usually work?
In general, yes. Relief from the often debilitating symptoms of pain and hematuria is frequently achieved by successfully decompressing the left renal vein, whether through open surgery or endovascular means.
And the future, especially for endovascular.
Endovascular strategies, particularly LRV stenting, are certainly being used and reported more frequently now. However, as we've emphasized, we still need more robust, long-term data on their safety, especially concerning stent migration and their overall efficacy compared to the established open surgical techniques.
But there's hope with new tech.
Yes. The continued development and adoption of those dedicated venous stents, designed specifically for the unique challenges of the venous system, holds significant promise. It's anticipated that this will increase the safety profile, primarily by reducing that migration risk, and ultimately improve the clinical outcomes for patients undergoing endovascular treatment for NCS in the future.
So it's a complex puzzle with many pieces, and some are still being figured out or refined.
That's a perfect way to put it.
Okay, so to recap for everyone listening, we've journeyed through the Nutcracker anatomy itself, highlighted that crucial difference between just having the anatomy, the phenomenon, and having symptoms because of it, the syndrome. We've explored the wide range of potential symptoms, from flank pain and blood in the urine to pelvic congestion issues. And we've navigated the current landscape of diagnostic tools and the various treatment options, noting the absence of a definitive gold standard in many areas and the ongoing evolution, especially in stenting. It's clear that Nutcracker syndrome remains a complex condition. Research is ongoing, and management strategies are continually evolving, particularly in that exciting, though still developing, area of endovascular treatment with dedicated venous stents on the horizon.
Absolutely.
And this leads me to a final provocative thought for you, the listener, to perhaps mull over. Given all the anatomical variations we've discussed and that incredibly wide spectrum of presentations from people who are completely asymptomatic despite having the compression, to those who are severely debilitated by it, what might be the undiscovered physiological factors that truly determine whether a person with LRV compression goes on to develop the full-blown Nutcracker syndrome?
That's the million-dollar question, isn't it?
It really is. Perhaps it's a complex interplay of their unique anatomy, their individual hemodynamics, the specific way their blood flows and the pressures involved in their system, and maybe other subtle biological or even genetic factors that we just haven't fully understood or identified yet. Something to think about.
Definitely food for thought.
If any of the symptoms or situations we've discussed today resonate with your own experience, or if you're simply curious to learn more about this intriguing condition, we encourage you to explore the cited references in our show notes, or, more importantly, to consult with appropriate medical professionals for more detailed information and personalized advice.
Please do.
Thank you so much for joining us for this deep dive into the complexities of Nutcracker syndrome.
Thanks for listening.